Good evening and welcome to this presentation of Prostate Cancer Connections, Genetics, Genomics, and Prostate Cancer. My name is Bo Stubblefield-Tave. I'm the Executive Director of US2 International, and we're very glad to have you with us. US2 International focuses on prostate cancer, providing support, education, and advocacy services for all those affected by prostate cancer. I hope you'll enjoy tonight's program. If you miss any part of it or want to see it again, please visit our website at www.us2.org. You'll see behind on the screen that we are all about helping men and those who love them by transferring resignation and determination and fear into hope. We're partnering in this program with our colleagues at ANCAN, and I will turn things over to my colleague Peter to tell you a bit more about his organization. Hello, Peter. While we're waiting, let me mention that we're also very pleased to be sponsored by two organizations. The funds from our sponsor help us keep all of our programming free. Tonight, we're sponsored by AstraZeneca and also by Janssen Oncology. Let me go ahead and introduce our presenters, if we can get their names up for a moment. We have four presenters today. We have Heather Cheng. She focuses on improving the care of patients with prostate cancer. She's an expert in prostate cancer genetics, is studying ways to use genetics to guide the care of prostate cancer patients and their family members who may also be at high risk for the disease. Dr. Cheng leads clinical trials on a variety of new treatments for prostate cancer. She's also developing new tests that could help guide doctors' choices of treatment for each patient and new blood tests to detect and monitor the progression of prostate cancer. Our next presenter is Katie Stoll. Katie is the executive director of the nonprofit organization Genetic Support Foundation, whose mission is to increase access to unbiased genetic counseling services and information. She's an experienced genetic counselor with a demonstrated history of working in multiple healthcare settings, including military healthcare systems, health maintenance organizations, community hospitals, outpatient clinics, and research settings. Katie is skilled in patient support, genetic counseling, education, and patient advocacy. We're also joined by two patient perspectives, two individuals giving us a patient perspectives. The first is James Barrett DeLong. He's a lecturer emeritus at the University of Washington School of Social Work. He has thrived for the past 19 years in spite of living with aggressive prostate cancer and experiencing a prostatectomy, 2 long treatments of hormone therapy, and 4 rounds of radiation over those years. He's a healthy 70-year-old, still with hormone-sensitive prostate cancer. He looks forward to thriving and surviving his prostate cancer for years to come. Last but not least, we have another patient advocate. I'll just refer to as Janet S. rather than mangle her last name. Janet was diagnosed with invasive ductal carcinoma at 46 years of age. Her doctor recommended genetic testing and counseling with Genetic Support Foundation, which revealed important family health history, specifically the inherited BRCA2 gene mutation. Janet is from a Swiss Catholic family with numerous relatives. Observing her family history, she learned that certain male relatives had prostate cancer and other cancers, including melanoma. She has shared that information with her own family, and now she'll share information with us as well. We thank all of our speakers for their participation. Now let me specifically welcome Dr. Heather Cheng, who will start us off.
Good evening. Can everyone see me and hear me? I'm going to look at Bo and give me a thumbs up if you can. Awesome. Okay. Well, thank you so much, all of you who are in the audience that I can't see, but who have joined us today. It's so exciting to be part of this event, and I'm especially I'm excited and honored to be joining with Katie Stoll, my esteemed colleague, and then also our two very, very special guests, James and Janet, and I'm really looking forward to their perspective. So I'm going to start off by trying to lay out the groundwork for telling you why this is important. Some of you, there were a lot of questions that came in, so some of you share already in some of the excitement. So hopefully you'll be able to sort of take some perspectives from what I'm going to talk about next. Okay, so the roadmap for this evening is that I'm going to start off by telling you what and why we should be thinking about genetic testing and what I'll now call biomarker testing, and I'm going to explain that and define it a little bit better in a moment. What and why, and why that's important for prostate cancer patients, and then how might management of a patient's prostate cancer change or be modified based on their genetic testing and also their biomarker test results. So I'm going to cover that part as a medical oncologist perspective. And then we're going to hear from James about his story and perspective. Then Katie's going to talk about genetic counseling, the meaning for family members, and updates in the National Comprehensive Cancer Network testing guidelines, which is a set of guidelines we use in oncology to help, and sometimes is covered also or used by payers like Medicare to consider reimbursement for testing. And then we'll also hear from Janet about her story. And then we'll end with some time for panel discussion and questions. I do want to mention things that I will not have time to cover today, but acknowledge that they are very important. And those are topics that we did have some questions about, but I won't be able to cover Decipher testing, Prolaris testing, Oncotype, ProMark, and polygenic risk scores, all of which are undoubtedly are very important, but could be a whole nother hour session of themselves. So I apologize for those of you who are mostly interested in that. We won't be able to cover that in detail today. What we will talk about and what I'm going to talk about when we talk about genetics. So there's two kind of, this can be very confusing, but I think one way of thinking about it, and there's some efforts to try to reconcile the language that we use. For the purpose of this talk, I'm going to talk about inherited genetic testing. So genetic testing of the DNA that is inherited from a person's mother or their father. Each of us has a 50% contribution of our genetic material from both of our parents. And this DNA, the master blueprints, are found in all of the cells of our body. They can be, if there is a inherited mutation in a gene that's important, can be associated with a higher risk of developing cancer. These are also called cancer risk genes or cancer predisposition genes. And you may have heard of some of them, for example, BRCA2 and BRCA1, and we'll be talking a little bit more about those genes. There's some others also of interest, but those are the ones that we know a little bit more about. And we can test for these inherited genetic risk genes through blood, saliva. Occasionally we use skin, and these typically do not change over time. You can test them once and and get a pretty good sense of what the lay of the land is. Now the DNA doesn't change, but the testing technology might change, or the information that we have to interpret the DNA may change. So I do want to be clear about that. If it's the case that somebody had testing 10 years ago, their DNA doesn't change, but our ability to sort of interrogate that and answer questions might be a little different because we have new knowledge. Then there are cancer-specific genes or biomarkers, which are DNA and other things, RNA, proteins, markers that are in cancer, for example, prostate cancer. And these are picked up primarily only in the cancer cells, and they are not inherited, and they are not found in normal non-cancerous cells. And these mutations and changes are not passed on to children. And in order to identify these, we have to test the tumor material itself. So that is, for example, blood biopsies, or if somebody has had their prostate surgically removed, the material that has been removed can be tested. Or in some cases, and this is not always the case, but increasingly there's interest in measuring the blood for these mutations. And I think those are useful in certain circumstances, and we're still learning about the best indications for that. Testing methods, again, as before, testing methods may evolve, And in this case, tumors may also evolve. So there were some questions about, when should we be testing? What's the best time to be testing? And so hopefully those themes will carry forward in the rest of the slides. So this is really a recent multi-institutional effort, and at the bottom are some of the major organizations that contributed to this. But this is a recent white paper which sort of calls attention to the fact that our field in medicine, in genetics, we need to do a better job for you, the patients, for consistent terms in what we talk about when we talk about testing for precision medicine. So the preferred consensus terms that we now, hopefully moving forward, will be better about using in order to minimize confusion is genetic testing for inherited cancer risk. And that is over to the side previously may have also been called germline testing, inherited mutation testing, and sometimes get classified as pathogenic or likely pathogenic variants. So all of those kind of refer to genetic testing for inherited cancer risk. In contrast, but related to that, is the biomarker testing, which really focuses on the tumor or the cancer itself. So things that are acquired, those are things that we also can call somatic mutations or tumor-specific mutations, acquired mutations, genomic mutations, next-generation sequencing testing. These are terms that are used more specifically to the cancer tissue, understanding the cancer tissue itself and not as much the inherited DNA. They are related, and I hope I'll show you how that is in the next couple slides. So again, genetic testing for inherited cancer risk, previously termed germline, biomarker testing, which is really focused on making decisions for treatment for cancer, also sometimes known as genomic testing. And then in the middle is this intersection where I kind of do much of my professional work, which is treatment using both of those pieces in that area of overlap for treatment decision-making, which includes genetic counseling, because there are times when this informs other cancer risk, in other words, risk of other cancers besides prostate, if that's the case. And then also if this information can be useful for family members in terms of thinking about their own cancer screening risk and things that they can do to be proactive. Another thing I wanted to mention is that genetics is complicated. Genetics are some genes on the sort of left side that interact together with the environment and then also interact with lifestyle and diet. And so the development of cancer is not absolute. So we have to factor in all of these things that contribute to somebody's lifetime risk. And there are common variants in the genome, meaning common findings, things that are very common in the population, but don't have a very strong effect on risk. And I'm going to illustrate that again in a different slide in a different way. But there are also rare variants that have a high effect or high penetrance, meaning if you inherit certain mutations, they actually increase your risk by quite a bit. And we know that that's the case for metastatic prostate cancer. And we know that about 5 or 10% of men with metastatic prostate cancer may have some of these inherited cancer risk features. So this is another way of looking at it. Not all genetic factors are equal. If you take the average lifetime risk of somebody with a man with prostate cancer, there are through studies that are called genome-wide association studies, some common, what we call SNPs or common findings, genetic variations in the general population. And each of those may change the risk by a small amount. Whereas some genes that we know much more about, like BRCA2, are relatively rare in the population, but confer a very high degree of risk. So instead of 1 or 2 steps up and down, it's an entire flight or 2 flights of stairs up and down. And that is enough to really change how we manage that person and how we might treat that person's cancer. So if there is prostate cancer that develops in somebody who has a germline or an inherited mutation in BRCA2, that man may have a much higher, does have a much higher risk. The estimates are 20 to 80%, but really kind of averaged at about 60% lifetime risk by the age of 85, with some variation depending on your family history of cancer that is associated with worse outcomes for prostate cancer as well. So in my practice as a medical oncologist, I see a lot of men with metastatic disease, and we are looking for that 1 in 10 man who might carry the inherited DNA repair mutation. When I say DNA repair mutation, I refer to a family of genes like BRCA2 that might increase the risk of cancer and may also have treatment implications. When they are inherited, they can be shared 50-50 with siblings and also with children. And so thinking about how we might leverage this information for the benefit of the relatives, and you'll hear more about that from our patients a little later in this evening. So that's, I think, the framework of what we're talking about. I will say again that for genes like BRCA2, which is the one we have the most information for, there's a substantially increased risk of prostate cancer, estimated at 5 to 9-fold above average risk, as well as some other types of cancer, such as male breast cancer and pancreatic cancer. It is associated with more aggressive prostate cancers and historically worse outcomes. But I would also say that in looking forward, as a researcher, as a scientist, as a medical oncologist, by better understanding the biology of BRCA and related cancers that have certain mutations present, if we understand how they work, we can do a better job screening for the cancer and detecting the cancer early, similar to options that are available for women with respect to reducing their risk of developing cancer. And there are also ongoing clinical trials and new strategies to improve the chances of cure if somebody does develop prostate cancer. And then even today, actually, just as of the last few months, we have new precision treatments that are available in the therapy toolbox for patients who have more advanced prostate cancer. And these are PARP inhibitors, which are now FDA approved, platinum chemotherapy, and we're investigating these agents in newer settings earlier in the disease, as well as new therapies. And so I guess what I hope to convey is not all the details, but to say if knowledge is power, so if we know more about these cancers, we can begin to leverage that knowledge and envision dramatically improved outcomes compared to when we didn't know as much as we did. So that's this sort of hopefulness. This slide, sorry, I think the animation is a little bit off here, so I apologize for that, but I'm gonna step you through it. So from the left is men or patients, men who may be at risk for prostate cancer, and we think about how we might take advantage of that information for early detection or screening for prostate cancer. So those are people who don't have cancer but might have risk of cancer. There's the next column is active surveillance. So there were a lot of questions in the question session about, active surveillance, and I'll come back to that. I just want to give a lay of the land of how we think about kind of prostate cancer disease states. So these are people who are at risk. These are folks who have prostate cancer that is diagnosed, but may historically be associated with low risk disease or low Gleason or low aggressive potential. These are cancers that I like to say might be really wimpy cancers. And it might be that's never life-threatening, and we can safely watch those without risking the side effects of some of the treatments that we have. Of course, if the cancer is more life-threatening, we want to treat it appropriately, but if it's not, we would want to avoid that treatment. So that's active surveillance, and then cancer confined to the prostate and its neighborhood. And then over on the right side, we don't need to go through all the details except for to say there are now multiple different disease states within cancer that has recurred after surgery or radiation. So there's a number of different disease states, biochemical recurrence, to all the way to the most advanced disease state, which is called metastatic castration-resistant prostate cancer. The point is just there's many different areas, and some of the newest agents are really focused on the sort of tail ends, the most advanced and kind of the most early areas. So here's a schematic of advanced prostate cancer. We know that over 20% of tumors have defects in DNA repair genes, and these genes are BRCA2, ATM, BRCA1, and genes that are in that family of genes. When those tumors have mutations in those genes, those represent treatment biomarkers and they predict response to platinum and PARP inhibitors. And then half of those men whose tumors have those mutations have an inherited component. So that's where those two Venn diagram, or the Venn diagram that I showed at the beginning, that's where there's some intersection between the two. This is just to give you an idea of, in that very advanced disease state that I showed you for patients, this is kind of the treatment toolbox, and it's been growing pretty quickly. Under that teal line there are sort of what I consider the precision oncology agents that are sort of new on the scene. Carboplatin is one that is an older drug, but we wouldn't typically use it in prostate cancer unless we have certain mutations present. Pembrolizumab, or Keytruda is the other name for that drug, is also available for prostate cancer patients if their tumors have evidence of microsatellite instability. And then rucaparib and olaparib were newly FDA approved oral pills for patients who have advanced disease and whose tumors or they have inherited mutations in BRCA1 and 2, and then a number of other genes that are a little less common but are still really important for patients who have those mutations. So that was just in May 2020. I'm not going to spend too much time on this slide, just in the interest of time. I will say here, there were, how do we measure what's in the tumor and how do we get that information? So as I alluded to before, when we're talking about biomarkers and what's in the cancer, it can be taken from the primary tumor, what was taken from the diagnostic biopsy, or the material from surgery, if surgery was done to remove the prostate, circulating tumor cells, which can be obtained from the blood. This is FDA approved, but typically is enumerating the number of cells. A metastatic biopsy, which is increasingly used, which is where a needle is placed into like a lymph node or bone to obtain material. Cell-free DNA, also called circulating tumor DNA, is also being used more. I will say it is commonly used, but sometimes we need to be thinking about what is happening in the context of the patient before we use it. So it's not that that is always a useful test, but in some cases it can be. For example, when the PSA is rising is a better time to think about that. And then germline testing or genetic testing for inherited cancer risk. That's the blood test or the saliva test. Really quickly, this is a study called the Gentleman Study, and this is to remove barriers and provide information, this genetic information for patients who do have metastatic prostate cancer and for their families. It's a web-based study. The URL or the website is up there, and it's available for people who don't have as much access to genetic counseling. So Katie's going to talk more about genetic counseling and why it's so valuable, but for some people that's not as available, and so this is a study that might be a nice option, and James can talk a little bit about his experiences with the study, but it is still open and the information is there. This is also to say we're learning more about more rare mutations and genes. And so there is an effort ongoing, or that's about to be launched in early 2021, called the PROMISE Registry. And it's a way in which we can learn more about some of the rare mutations or less common mutations that we're studying. So I talked a little bit about the two ends of the spectrum, the more advanced disease for which there's those new exciting drugs. And now I'm going to shift to the early detection or screening really quickly. I'm going to talk about a couple trials and then hand it over to James. So this is really to say, again, the man in orange is the man that I might see in my medical oncology clinic. If there is an inherited DNA repair mutation such as BRCA2, we want to make sure we extend the benefit of that knowledge to his family. So again, female relatives have good, more tailored screening and risk reduction strategies, and we have to sort of catch up for the men. We know they're at more risk of prostate cancer, both because of their family history as well as their mutations. So I'm going to skip over this. The main point of this slide is to say that we have good evidence from families that have BRCA1, 2, and other genes that PSA is indicated. So for a strong family history of cancer, relatives who have prostate cancer in their family are not at average risk. And we should be thinking about systematic PSA screening And for men who are at especially high risk because of a BRCA2 germline mutation, for example, we hope we can do better. Can we lower we know PSA screening is not perfect. Can we lower the PSA threshold? Can we use MRI? Can we use newer biomarkers? And that's sort of the theme of the next two slides, which are ones I just want to make you aware of. Without going through the detail, these are two studies that are available for relatives. So men who may have BRCA1, BRCA2, HOXB13, which is another prostate cancer risk gene, ATM, TP53, ones that we're also suspicious of and we're still learning about. If there's a family history of prostate cancer, especially if it is more aggressive and advanced prostate cancer, and somebody has a mutation in one of these genes, then their male relatives, ages 30 through 70, who don't have prostate cancer but who might be at risk, can participate. And this first study is at the National Cancer Institute in Bethesda, Maryland. The contact information is there, and they do cover the cost of travel if people live further away. This next study is just opened at the University of Washington. It's a similar study. It's called Patrol. I'm not going to go through the details except to say this is another opportunity for men who may be at risk, and the contact information is shown there. And then to go back to this schematic, I think the point is that we know much more about BRCA2, but there are other genes for which we're still learning, and that's just as important for the families that have those inherited genetic mutations where the risk is suspected, but the data is not firmly there. So that's the work we do together. Okay, also just very briefly, we have a genetics clinic at the Seattle Cancer Care Alliance for medical oncology and genetic counseling to discuss some of these innovations and sort of the rapid changing landscape. A lot of this is changing really quickly. There are other comprehensive cancer centers that have cancer genetics clinics. And so I think if you're uncertain and you might have one of these mutations, to really seek one of these clinics out, because they do have dedicated expertise and resources. And a lot of this is changing over time. And there's a lot of research opportunities, both for treatment as well as for screening. Even if you've had testing in a very strong family history, I think there was a question about this. There are other opportunities like for additional follow-up, and Katie and other genetic counselors may be able to put you in touch with some of these other opportunities to solve if there is a very strong family history, but testing is done and there isn't a gene mutation identified, there are additional opportunities. And there's also management changes also. So I think this is towards my last slide. Genetic testing is increasing, both from a treatment standpoint as well as for families. Biomarker testing is also increasing. There are times when people get biomarker testing and then that raises a suspicion that there's an inherited cancer mutation. And so that interface is also really important to think about for prostate cancer patients. Ongoing research is happening as we speak about how inherited gene mutations may affect treatment and the response for patients who have prostate cancer, as well as the cancer risk for male carriers. And the same is true for biomarker testing. There's ongoing clinical trials for men with BRCA mutations and related inherited cancer risk mutations. And I encourage you, if you're thinking about this and have questions, to ask your oncologist, ask your urologist, seek out a genetic counselor, visit a center of excellence for a second opinion, and really think about this, because I think it's new enough that sometimes not all providers are necessarily up to speed on this, but it's a really exciting area, and we're all kind of making strides together as we go. So here's a shot of where I practice and some information about if you wanted to visit us. And then I'm happy to take questions at the end with the panel. I do acknowledge that there were questions we weren't able to get to, and then I'm going to hand it over to James. So I'm going to stop my share here. And James, are you there?
I'm here.
Oh,
yes.
wonderful. Oh, okay.
Oh, okay.
Well, thank
So
you
I'm
so
on.
much for sharing your story, I'm going to hand it over to you.
Okay, excellent. Thank you. Thank you, Heather. First of all, thanks to all of the sponsors and for us too. And Heather, thank you very much for inviting me to participate. I really appreciate it. And thank you, Bo, for your introduction. So my story, 2 years ago, I was 2 years into metastatic prostate cancer, and my SCCA primary oncologist, brilliant clinician researcher, Tia Hagano, urged me to participate in Dr. Cheng's gentleman's study. I did have a family history of breast cancer, particularly on both sides of my family. So I followed through, and they made it extremely easy to participate. It was free, it was simple, they handled all the paperwork. All I had to do was sign the consent and then fill out the saliva test and send it in. And then I got the results, and I was one of those people, one of those men in orange circled. I was one of those already high on the staircase with the BRCA2 mutation. It was shocking and upsetting, and yet it also explained why at age 51, with no risk factors, all of a sudden I found myself with Gleason 8 prostate cancer in a doubling time of 1 to 6 months. So in a sense, that was a bit of a relief. So what happened is we met with a genetic counselor from Color Genomics, and then also with a genetic counselor from Seattle Cancer Care Alliance. And then I met personally with Dr. Cheng. And she detailed on a single piece of paper all the drugs that were available right now for people with my mutation, and also detailed a number of drugs that are in the pipeline and may be very helpful, drugs that may work very well for people with a BRCA2 mutation, but not at all for other people with prostate cancer. The options filled the page. Now, this sounds ironic, but I actually left the meeting feeling like I was walking on air, quite elated, feeling optimistic. I remember thinking, geez, I'm sure lucky I have the BRCA2 mutation. Kind of funny, huh? Now, I still have the paper that she wrote, and I'm just gonna put it right here for a second and just kind of scan up and down it. Okay, and that's just to say that 2 years ago, that was a full sheet of paper, and now there are many more options and many more options coming online. I believe that information is power, and Dr. Cheng provided information with me. I believe in science, and she's a scientist, and so this information was incredibly helpful. I encourage all men with metastatic prostate to check out the gentleman's study, and please consider participating. I left that meeting eager to share with my family members, both my daughters and also extended family members, what I had learned, because I knew that it was probably going to help me live many years longer, and that it could potentially change the life trajectory of my family members. So my wife and I started with our daughters. They each had a different process of going through, of course, shock and being upset and kind of thinking the worst. And then they settled down, and eventually each got tested. My daughter, who lives locally, is negative for BRCA2 and all the other ones that she tested for. My daughter in the San Francisco area, however, tested BRCA2 positive. So Heather had mentioned that 50% possibility. Well, one daughter yes, one daughter no. And what my daughter did in San Francisco, she feels lucky to live there because she signed on with UCSF's hereditary cancer care center for all her BRCA2 related healthcare. She sees a nurse practitioner every 6 months to discuss what she needs to be doing because she's BRCA2. Now in her mid-30s, she's alternating every 6 months between a mammogram and an MRI. She takes great care of her skin. She sees a dermatologist regularly. She knows when to take action regarding the possibility of ovarian cancer, which is considerably greater for her than the general population. In sum, she feels in control of her fate as much as anyone in life can be. And I feel confident that she's likely to live far longer, knowing that she has this mutation and taking preventive and at some point early intervention action if needed. As her father, that's worth its weight in gold. Now, I talked to many of my extended relatives and family members, and to this date, to my knowledge, none of them have been tested. And I followed up with many of them this week and learned that a few of them are going to talk to their doctors about the family history and this possibility and about my history. And as I learn more, I hope I get better at talking with other family members about the benefits of being tested. So I encourage everybody to think about your family history, to talk to your doctors about family history and the possibility of getting tested. And keep in mind that doctors are still learning about the value of testing. And so if your doctor isn't hot on the idea, that doesn't mean it's not a bad idea. You can still be tested and it can still be useful to you. I have a few closing remarks and important acknowledgements. Although I'm in stage 4 cancer, I'm very optimistic about living many more years. I received superb oncological care for 18 years from Dr. Tia Hagano at SCCA, and also multiple times CyberKnife from Dr. Bob Meyer at Swedish Radiotherapy Center. As you can tell, Dr. Cheng infused me with hope a couple years ago through her meeting with me. And I know that precision treatment for all of us is an absolutely critical arm of a multifaceted partnership to combat any kind of cancer. I benefit from the eclectic wisdom of us two support group leaders and members. Thank you, Dick Swanson and Ed Weber from the Bellevue, Washington, us two support group for your leadership and your service. Most importantly, thanks to my wife, Janet, best support ever, and to the wisdom and support of friends and family members who provide support and who pray for me along the way. I don't put all of my eggs in one basket, meaning I don't adhere solely to one theory of cancer treatment. So in addition to utilizing the best of state-of-the-art standard care practitioners, I use providers from adjunct cancer care organizations. I'm on the careoncology.com metabolic treatment for cancer using safe, repurposed generic drugs. I use websites like Beyond Conventional Cancer Therapies.ngo, a comprehensive science-informed source for integrative cancer therapies. And I use Joel Nowak's excellent cancerabcs.org website and his support groups. Shout out to Joel, a fellow MSW. I have one final comment I'm compelled to make. Fundamentally, I know I'm alive today in part because of countless unearned advantages throughout my life, including superb healthcare insurance, not available to millions of Americans. These advantages accrue to me because I was born into a middle-class family with college-educated parents, and I live as a white, male, cisgendered, heterosexual, and middle-class person, sadly, within a shamefully inequitable and unjust society. So, acting for social and racial justice in whatever arena each of us has influence is something all of us can do and need to do to reduce health disparities and inequities in our country. Thank you very much. I'm muted and I'm off.
Hey, well done, well done.
Thank you.
So well done.
I don't know how long it took. Wow, it's probably too long.
Am I on now?
Yeah,
Bo?
let me just say I want to welcome Katie Stoll. I certainly want to thank James and Heather for their excellent work, and we'll get a chance to thank them again later. Please go ahead, Katie.
Okay, well, thank you so much. Thank you, James, for sharing that incredibly powerful story. There was so much, and the information being so powerful for you and your family, and Dr. Cheng infusing you with hope. I thank you for sharing that. I'm going to share my slides here. All right, are my slides up? I'm Katie Stoll, and as I was introduced, I'm a genetic counselor and I work for Genetic Support Foundation. I'm going to talk a lot about genetic testing, so I wanted to make sure just to acknowledge that I don't have any financial connection to any of the testing labs that I'm talking about, or any of the genetic tests I'm talking about. I come from a position of really just wanting to provide information about genetics and health, and also really trying to help support families navigate this information so that they can use this to better their care and for prevention and early detection of cancer for their family members. So the focus, there's so much to talk about on this topic, and I've really struggled with what to include and what not to include. I thought I would just make a mention that Dr. Cheng and I did give a lecture for an S2 event a couple of years ago in Seattle, and it's still recorded and available on the S2 website. And I decided to not include a lot of kind of background information about, too much background information about kind of inherited genetics and genetic testing, but there's more in that talk from both Dr. Cheng and I that might be worth referencing if you'd like a little more background information on this topic. So I'd encourage you to look there. But today, I'd like to focus a little bit on providing an overview of all of the current recommendations with regards to genetic testing in prostate cancer, specifically to genetic testing for inherited genetic mutations. I'd like to share more about the role of genetic counseling and how that could potentially be helpful for you, and then help to convey information about the meaning of genetic testing for family members, although I don't think I can do that as well as James and our next speaker, Janet, can do. So when I'm talking about genetic testing, I'm really referring specifically to genetic testing that's looking at mutations that are passed on from generation to generation, and specifically genetic changes that are related to a higher risk for cancer. I think just as a general overview, all genes are essentially codes to build proteins, and those proteins have some job in our body. The job of the genes that we're talking about with regards to hereditary cancer risk, their role is to repair genetic damage or DNA damage. All cancer occurs due to genetic damage, but it's usually not directly related to genetic changes that or mutations that we inherit. So when we're talking about inherited risk, we're talking about a situation where somebody has a gene passed on to them with a mutation or a typo in the DNA code for which it cannot produce the protein to repair genetic damage properly. And because we inherit our genes in pairs, we get a set from the egg and a set from the sperm that make us. To inherit one mutated copy of a gene or one non-working copy means that you have one working copy and one non-working copy. That one working copy may carry you for a long life, never failing. But if you start off with only one good copy from the get-go, you are basically at you have a higher likelihood to develop cancer. we know that there are many different genes that are involved in repairing DNA damage. And we know that these different genes are associated with different types of cancer risk. Most genes that we talk about are associated with more than one cancer type. So we talk about the BRCA2 gene, for instance, especially with breast cancer, prostate cancer, ovarian cancer in women. But we know there are other genes that play a role in prostate cancer and colon cancer, for instance. So important to recognize that the cancer risks are very much specific to the specific genes that we're looking at. And as Dr. Cheng mentioned, we have a lot of information and much thanks to the research and work that she's done in regards to BRCA2 and BRCA1 and prostate cancer. And we're still learning a lot about the role of other genes in prostate cancer risk. We had a lot of questions come in with the registration specific to specific genes and cancer risk. And I think tonight we don't have enough time to get into all we know about all of the specific genes. And I don't even want to spend too much time on the specifics of BRCA1 and BRCA2. I do think it's worth noting that BRCA2 is an especially important gene with regards to prostate cancer risk. And we see some studies suggesting that the lifetime risk for prostate cancer exceeds 50%. And we know that as prostate cancers can be more aggressive in men with BRCA2 mutations. But these genes are carried by both men and women, and they confer higher cancer risk to both men and women. And you can see it can look a little different in that regard. So some common questions about genetic testing, some that we received before the webinar tonight. Many people wondering if genetic testing can be important in their specific case. Many people with questions about insurance coverage for genetic testing, and some with questions about what the meaning of the results would be for their family members, and also what the results would be mean for their care and treatment. I'm going to start by talking about just the guidelines, because this really does relate to the likelihood of insurance covering genetic testing. And in the last couple of years, we've seen the guidelines broaden quite a bit to allow for greater availability of testing to men with prostate cancer. We typically look to the National Comprehensive Cancer Network, or NCCN, which is a not-for-profit consortium of leading cancer centers, experts at leading cancer centers who develop evidence-based guidelines, both for cancer treatment, but also for how we take care of people who have a higher risk for cancer due to a genetic cause, even if they haven't developed cancer yet. And NCCN's guidelines regarding prostate cancer screening specifically have expanded, I think, more than any other cancer site with regards to the BRCA1 and 2 genes. At this time, the NCCN guidelines say that genetic testing for inherited cancer risk should be considered for any man with very high risk or high risk prostate cancer. And it should also be considered for people with intermediate, low risk, and very low risk prostate cancer if they have a family history suggestive of cancer risk, or if they have cribriform or intraductal pathology. So the guidelines are pretty broad in that way, I think, especially when you start looking at what NCCN means when they're talking about family history of cancer, family history suggestive of cancer risk. Medicare has guidelines for coverage of genetic testing as well, and they do not, they're not exactly the same as NCCN, but I think that this is kind of an important reference, and this also changes. The Medicare's guidelines on genetic testing do get updated from time to time as well. Some important things to recognize about Medicare and genetic testing is that typically genetic testing is only covered for people who have a diagnosis of a related cancer, and guidelines are specific to BRCA1 and BRCA2 testing, or to genetic testing for mismatch repair genes. Focused on the BRCA1 and BRCA2 genes, Medicare will cover genetic testing when the results may change care and management, typically for men with metastatic prostate cancer, For men with prostate cancer with a Gleason score of 7 or higher, and one or more relatives with the following, or with if they have Ashkenazi Jewish ancestry. So looking at the family tree, we're looking at first, second, and third degree relatives. So if you are kind of expanding out your family tree, you'll see that takes you out to cousins, to great aunts and uncles even. So really knowing your family history can be really important in recognizing if you could be at risk to carry a BRCA1 or BRCA2 mutation, and really is there family history there that, that meets this criteria. So ovarian cancer in any family members, and thinking about both your mother and father side of the family. Breast cancer in any relative at age 50 or younger. A family history of metastatic prostate cancer, a family history of pancreatic cancer. If you have 2 or more relatives with breast or prostate cancer at any age, that also meets the Medicare criteria as they're currently written. Now, as I mentioned, Medicare's guidelines are really focused on BRCA1 and BRCA2 in this case. However, I think it's important to note that NCCN recommends consideration of a gene panel that includes more genes than just BRCA1 and 2. And as Dr. Cheng indicated, there's still a lot we have to learn about prostate cancer risk with some of these other genes, but at a minimum, NCCN recommends a consideration of a panel of the genes listed here, and recognizes that sometimes other genes may also be included. For decades, we were really only testing for BRCA1 and 2, and it's been within the last probably 5 years or so that it's quite common for people to have testing with much broader panels that may include dozens of different genes related to hereditary cancer risk. So when you're thinking about a genetic test, please note not all genetic tests are the same. I did see some questions come through regarding direct-to-consumer type testing like 23andMe and ancestry testing. There are lots of different types of genetic tests, and it's a big business right now. Genetic testing, quite competitive, and there's not really a standard in terms of what genes are offered on these panels and how testing is done. So I think making sure that that the genes that are included are the genes that are most important to the family history and cancer type. I mentioned 23andMe specifically because this is quite a common at-home test that people have done, and I've met with many patients who have thought that they had complete BRCA1 and BRCA2 analysis because they had a normal 23andMe test, but please know that the 23andMe test is really only looking at 3 specific variants in the BRCA1 and 2 genes. If you think about each gene being like an instruction book to code for a protein, look at a complete test would be reading that instruction book from cover to cover, looking for any typos or mutations in the DNA from start to finish. But there are some tests that are really only looking at specific points in the gene and are not giving a complete picture there. So a negative test may not be as informative. The 3 mutations specifically that the 23andMe test looks for are ones that are most common in people of Ashkenazi Jewish ancestry, but it's not a very the detection rate for mutations in people outside of the Ashkenazi Jewish population is not very high. So knowing which laboratory is performing the testing, and I think some other questions that I hear people concerned about, and I think can be asked is, how will your data be protected? Your genetic information is really important. One of the most, it's not like a credit card number that you can cancel and change numbers. It's very important personal information. So knowing how your data will be protected, there are certainly many labs and different studies looking at genetic testing. And so genetic information may be used for further research. And I think that can be wonderful for furthering our understanding, but I think understanding how your information will be used and knowing and how knowing what you're consenting to is important. I think understand how you'll learn results. Sometimes I find that people have had testing and they never were provided a copy of their test results or any information about it. So having a plan at the time of testing to know how you'll learn about your test results can be very important as well. I also want to make people aware of the potential for genetic testing fraud. So this has been a really big deal. You might have heard about this more in the news last year, but last September, the Department of Justice announced that they had this Operation Double Helix, in which they had identified over $2 billion in Medicare fraud related to genetic testing. And these tests are typically being promoted as cancer genetic tests. And it's, I think, as the Medicare guidelines expand to include coverage for more people, I think that, of course, scammers have figured out that this might be a way to make some money. And I have personally had patients who have had phone calls after they've met with me and they thought it was related to my visit. I actually have one of the test kits. Somebody called me and said, I just got this in the mail, and this isn't how you described to me my genetic test would look, but they had somehow gotten information just to make a cold call to her and offer this genetic test that they said Medicare would cover. We also have seen booths set up at the county fairs in our area and different health cares, doing informational visits to long-term care facilities. So it's really been kind of a big issue, and I think that it's been a little bit like whack-a-mole to find out who's setting up these labs and doing this type of testing. So as much as you can, ensure that you have an idea of where your testing is going. And of course, if you're a healthcare provider, your oncologist, your urologist, your genetic counselor is helping facilitate testing order, you're going to have a lot more assurance that it's going to a reputable lab than if you're signing on for testing in the community. All right, so genetic counseling. So I always like to talk a little bit about what we do as genetic counselors, because I think that sometimes kind of wading through all of this information can be a little overwhelming, and that's really what our role is as genetic counselors, is to help people navigate all this information, to help people understand the different risks and benefits and limitations of different genetic tests, to keep up to date with changes as we learn more. So typically, meeting with a genetic counselor involves some review of the family health history, really drawing out the family tree, talking about one's personal health and medical history and other factors that may play a role in cancer risk. And then providing information and support about what we're seeing with the assessment. Does it look like it's suggestive of a hereditary risk? Do we see that this meets the clinical criteria for which genetic testing would be recommended? Where would we send genetic testing, and what are the potential benefits and limitations and drawbacks of that testing for that person? And what's this information going to mean for not only the patient's care, but also for their family members? And I think that's one role that genetic counselors can especially play an important role, is how to share this information with your relatives to help people make use of this information and be empowered by it. I think it can be pretty overwhelming to give this information, and as James mentioned, I think many providers are still learning or maybe don't appreciate yet the importance of this information and care, so it might not always come up, but I think that it can be really helpful, and advocating to talk with somebody who can walk you through it can be helpful, and a genetic counselor can do that. One of the questions that came up prior to the webinar, and I just wanted to touch base because this is one of the biggest risk factors that we talk about as a concern for people when we're considering genetic testing, is the possibility of genetic discrimination. So people worry, could their information from a genetic test be used against them in some way? There is federal law that has been in place since 2008 called the Genetic Information and Non-Discrimination Act, or GINA for short. Oh, sorry, I have a little typo in my slide here. But basically, the Genetic Information and Non-Discrimination Act helps provides federal protection to prevent discrimination from employers and from health insurance with regards to genetic information. A genetic susceptibility can't be considered a pre-existing condition, and this predates the Affordable Care Act in that way. However, there are not federal protections to prevent discrimination in other areas of insurance, such as long-term care insurance, disability insurance, and life insurance. So some people do consider that carefully when deciding about genetic testing. So you might consider reaching out to a genetic counselor to talk if you meet any of these criteria, which we've reviewed here, and genetic testing hasn't come up for you in your healthcare. If you have a family history of concern, or really just questions about what this all means for you, I think talking to a genetic counselor doesn't necessarily mean that genetic testing is going to be done, but it can provide information that can help you make an informed choice about that. In conclusion, guidelines have expanded a great deal to allow for genetic testing to be available to more men with prostate cancer. Not all genetic tests are the same, so be sure you know what to expect before testing. And genetic test results can be important for your care, but also allow for cancer prevention and early detection for your family members. And genetic counseling can provide information, guidance, and support. So thank you for that. And now it is my pleasure and honor to introduce Janet Shimabukuro, who I first met just almost a year ago, this coming November, and I met Janet, as a patient when she was newly diagnosed with breast cancer. And I have now have the fortune to work with Janet more as a health advocate. She has really done so much, all while undergoing treatment for cancer this year, and sharing her story and the story of her family to help others, and to ensure that her family members can know about the importance of genetics for their care with regards to prostate cancer, breast cancer, ovarian cancer. So thank you so much, Janet, for being here with us tonight.
Thank you, Katie. So I'm excited to be here tonight to share my story, and it really starts sharing a little bit about my father. So a little bit of background. My father had prostate cancer. It started with his PSA increasing, and in his late 50s, and the doctors decided that he needed to have surgery. So that was in February of 2000. Unfortunately, the day after his surgery, a blood clot traveled to his brain and he suffered a massive stroke. My dad was a proud, hardworking Swiss farmer. He lived to work on the farm, and not being able to work was really, really tough for him. Unfortunately, he was permanently disabled for the next 10 years. And during that time, his cancer spread to his bones before he passed away at the age of 72 in 2010. So the following year, his cousin, also another farmer, was battling prostate cancer and later pancreatic cancer, and he passed away. So that was the year after my father passed. And then that same year, his daughter tested positive for, or was diagnosed, for stage 3 breast cancer. And then in January of 2012, she had genetic testing and learned that she carried the BRCA2 mutation. But because her mother had had breast cancer earlier on in life, she just assumed that if she had any predisposition from her family, that it must have come from her mother, and her dad wasn't around to be tested, because, we really didn't think about father, it was always looking to the mom. So then we're going to fast forward 8 years, and that's where my story starts. So that's when my husband felt a lump in my breast while we were cuddling in bed. And I share that with you because I think people are embarrassed to say that it was their spouse that found their cancer, but I've learned that a lot of times it is. So I think that we shouldn't be afraid to share that. My tumor was about the size of a marble, very hard. First came for the testing, first came the ultrasound and then the needle guided biopsy to find out that I had stage 1 invasive ductal carcinoma. So my breast cancer was triple positive, which pretty much guarantees chemotherapy. And I think you'll notice I look quite a bit different with my hair than the photo that you saw at the beginning of the presentation tonight. So my chemotherapy started last November. I have the port here in my chest, and I met Katie for genetic counseling because at the time I was 46 years old and really no risk factors for breast cancer. It was really kind of a shock. So Katie had me do the whole family tree. And when I met with her, I laid it out and I said, Katie, I'm convinced that I don't have the same BRCA mutation as my cousin because there really wasn't history of early onset breast cancer in my family when I did the family tree. However, there was aggressive prostate cancer with my own father, as well as my uncle, who, by the way, is doing great now, but he has battled prostate cancer, melanoma, and most recently stomach cancer. So it was during that meeting with Katie that I learned that the BRCA mutation often presents as prostate cancer in men. Who knew that? I'm sorry, I had no idea. I knew about the BRCA mutation for about 8 to 10 years, but never that link between prostate cancer and breast cancer. And I just wondered why when I would go for my regular mammograms was I never asked about my dad's health history. So I recall the day that Katie called me to share that I tested positive for the BRCA2 genetic mutation. So it is the exact same mutation that my second cousin has. So for the first time, we knew that it came from our fathers because that is the only link that we have. That's our only blood connection. So I have a strong faith, and it was between tears that I remember sharing with Katie that I realized that I was the missing link, and this was the reason for my cancer. I truly believe that God chose me to have this cancer so I could share this important information with my family. Even my husband, who isn't the religious type, felt strongly that I was going through this in order to help others. So for me, this information really sealed the deal for my surgery decision because on that day, I realized I wouldn't be having a simple lumpectomy. I knew that for me, the right decision would be a bilateral mastectomy and a preventative hysterectomy to prevent ovarian cancer in order to protect my health. Just a few months before my diagnosis, I lost a coworker to ovarian cancer at 55 years old. It was a very painful, horrible journey for her. So I knew that I had to take the steps necessary to protect my own health. So I was quick to share this news with my family, my immediate family and my extended family. And we decided it would be most efficient if we went to the oldest living relatives. And if they tested for instance, my father's siblings that are still alive, and if they tested negative, then their children and grandchildren would know that they couldn't carry our family's genetic mutation. So we've had more than a dozen family members tested since my diagnosis and finding out that I carry BRCA2. So my sister Eileen tested positive. I have 2 other siblings. My brother tested positive and one sister that tested negative. And with my sister, her doctor that tested positive decided to do a baseline MRI just to, do the baseline test. And to her shock, they discovered that she had stage 1 invasive ductal carcinoma as well. And her doctor explained that it would be likely that it wouldn't have been caught in her regular mammograms and her regular testing. So she felt so fortunate to have this information that led to her having the test. So she opted for a bilateral mastectomy and a BSO surgery to have her ovaries removed to minimize her risk. And because our mastectomies were scheduled during COVID, we couldn't have our families with us in the hospital. We joked that our husbands literally dropped us off at the curb at the hospital. I don't think it was coincidence that our surgeries were scheduled on the exact same day, an hour apart. So on March 31st of this year, we both had surgeries, our bilateral mastectomies at St. Peter Hospital here in Olympia, Washington, and they were wonderful, and they allowed us to room together. So we were there to support each other through this, also through the reconstruction phase as well. So over the past year, my story, I had 6 rounds of TCHP chemotherapy, the stuff that made me sick and lose my hair, followed by bilateral mastectomy, reconstruction, and hysterectomy. And I'm thrilled to report to you all tonight that I had my last infusion of Herceptin today, and I will have my port removed hopefully by the end of the year. So my journey is ending today. Yeah, super excited. My sister and I both feel strongly that this information truly was a gift for us and has helped extend our lives. We were born with our genetic makeup, and getting tested isn't changing anything, but it's giving us important information that we can use to protect our health. So I like to explain to others that my family's BRCA mutation was really hidden in the generation before us because it was in the men. No one was making the connection between prostate cancer in men and breast cancer in women. And it often presents as breast cancer in women so much younger, which it has in my family. So my cousin and I were both diagnosed at 46 years of age, but her niece developed breast cancer around age 30. And the recommendation for my daughter is if she tests positive for the BRCA2, that she would have her preventative surgeries 10 years before I developed cancer, which would be to have her preventative surgeries by age 36. So it really, that information for her would play a role into when she chooses to have a family, which, she wants to have kids one day. So she wouldn't wait too long to have her children. So between my siblings and I, we have 5 children aged 16 to 19 that will get tested. And if they test positive, they'll take steps, for their health, whether that be screening or surgeries. So my message to you tonight is that cancer is not a death sentence. Regular screenings and self-exams are so important, as early detection makes all the difference. And this is especially true for those of us with high risk. So be your best advocate, and if there's a family history of cancer, seek genetic testing. Thank you.
Absolutely a fantastic story. I want to thank Janet and James, particularly as patients, but also our clinicians, Heather and Katie. One of the things that I say about prostate cancer is it's a personal struggle, a family affair, and a community crisis. I'm an 11-year survivor myself. I lost my sister Barbie to breast cancer at 34. And like you, Janet, I recently learned of the BRCA2 gene connection. And you all are sharing information that many of us did not know. And really thank you for that. We're about to start our Q&A process. I want to ask you to use the Q&A function that's there on your screen. We do have had over 100 questions before we ever started, and we've got more coming in. So we may not be able to get to your specific question, but we encourage you to present it regardless. And I will start off with one question that was selected for us. Would a person who died of prostate cancer have automatically had his tumor tissue tested during removal to see if there was a germline or somatic mutation? My husband died of prostate cancer, and I want to give my adult children the best advice I can. Am I correct in thinking that if his cancer was from a somatic mutation, they are at average risk rather than elevated risk?
Maybe I'll start answering that, and then Katie can kind of add on as well. So first, thank you for asking the question. I'm very sorry to hear about your husband. It is not standard. Actually, a lot of what we talked about today, and reflected in the statements by James and by Janet, is that much of this is very new. A lot of this is really the awareness of the connection between BRCA2 and prostate cancer. Even though there has been suggestions of it dating back a decade, how much it is impacting many of our patients was not really apparent until 2016. So it's only been really in the last 4 years that this is really on an increased awareness and that it affects as many people as it does. So the first is it is not standard necessarily for it to have been tested in the tumor. And it is also not necessarily true that it was tested in for inherited cancer risk or in the germline. And so that is something that is there, if there's a history of, and it's important for the children to potentially meet somebody like Katie and talk about the rest of the family history and consider, what options there are. And there are sometimes some strategies to go back to those tumors and ask some questions, but not guaranteed at all, which is why education and awareness is so important.
Yeah, and they could, with the history alone, I'd say in most cases, genetic testing for the adult children would be considered appropriate just with the history of metastatic prostate cancer in their father. And, as Dr. Cheng mentioned, about 12%, or did you say 5 to 10%? What's the percentage?
It's 12% in metastatic.
Right, so
5% if you look at advanced and high risk disease. So it depends on what slice of the pie you're taking, but.
Yeah, so if you're thinking 12% of men with metastatic prostate cancer will carry a mutation in one of these genes, then the chance that we'd find something and the children would be half of that. So about 6% chance that a test would come up with a genetic change that could have importance for their care. I think in meeting with somebody to go through this with them, sometimes genetic testing doesn't give us an answer. In that case, you might have a 6% chance that you're going to have an informative positive result that's going to guide care. But for that other 94% of people that don't have an informative result, since we can't test necessarily somebody in the family who's had cancer, we would really recommend care be guided based on the family history. So, taking a look at the bigger 3-generation family tree and really making some guidance around screening for cancer based on that, if genetic testing doesn't give an answer, can be helpful too.
Yeah, I wanted to add on that point, Katie, and then also on a question that came up about the connection of why the importance for Ashkenazi ancestry versus other potentially known risk groups. So I think we have more knowledge about Ashkenazi ancestry patients or persons because there are known founder mutations that exist in higher frequency in the Ashkenazi Jewish population. There are other risk groups. So for example, African-American or Black men are at increased risk of prostate cancer. And we don't know all of the genetic factors that contribute to that risk. And there are probably other factors as well, environmental, access to healthcare, other disparities, but we do know that there's a genetic association and there's active research ongoing in that area. But it doesn't exclude a BRCA1 and 2 and other mutations. So I guess one of the points is, even if there's a very strong family history of cancer and the testing is negative, that doesn't mean that family members are not at risk for prostate cancer. That's not the message. The message is we haven't been able to put our finger on what that risk comes from, but those relatives should still absolutely share that with their doctors and consider PSA screening. And in some cases, research opportunities as well. But a negative test has to be interpreted very carefully. It does not mean there's no risk.
Yeah, and just, the frequency in people of Ashkenazi Jewish heritage of carrying a BRCA1 or 2 mutation is about 1 in 40, where in the general population it's closer to 1 in 400. So that's part of the reason with the guidelines that's specifically called out, because just the likelihood of a positive result is much higher just based on ethnicity for BRCA1 and BRCA2 specifically.
One of the things I really was struck by both hearing James and Janet's sort of stories, and I can't thank you each enough again for sharing it. The things I think about and I'm kind of haunted by, and I think both of you kind of mentioned, is that the link between men and some of these genes and women, and then there's a divide there, is just really to the audience, is really to expand and think about both sides of the family and think about cancer on both sides. And I wonder, actually, maybe James and Janet, you can talk a little bit about sort of how that went among maybe Janet, about your male relatives. I guess it started with your father and your uncle, but I think that's a really important message to disseminate. And so I'm so glad you're both here with us.
I think it's one of the most important messages to share. I really do, because I just find that even people in the medical community still think that it's, breast cancer the predisposition can only come from my mother's side. And I'll just share a story that was profound to me today that I shared with Katie. I was at my oncologist's office for my treatment, and a nurse was checking me in, and she shared that she's been a nurse for 10 years, but is new to oncology. And then I just told her that I have really great care where I'm at, and she agreed. And she just said, I have some experience with a cancer and treatment. That her own father had melanoma and prostate cancer all before age 60. And I asked her if he had genetic testing, and she said no, that he hadn't. And I just said, that's really important information. And so that's somebody already in the circle. And she said, I've got people here I can ask. And I said, please do, because she shared that she's 40. And I said, now is the time when you would really benefit from that. And your father would have potentially other treatments available. So I just think that it's so important, that connection. And I'm excited that the realization is happening and people are sharing that story, because it could have changed my course of action. I might not have had cancer if my dad had known he carried that, and I would have, because I'm one that would have had those surgeries preventatively for sure. So yeah, very exciting.
Yeah. A question I had, actually, that maybe you could speak to, James, is you talked about that it was hard for your daughters. And I think or at least I, spend a lot of time trying to think about all the benefits, and I get really excited about it. And I say, there's all these, knowledge is power, and we can take, but it's also comes with some, fear probably, and nervousness and trepidation. And maybe you can speak about how that was, watching your family or talking to your family, and how that went for you.
Yeah. And first, a comment about the previous question, which is that just the idea of a man having the breast cancer mutation is weirdly shocking to men, and men don't think of higher risk for breast cancer even from that. So I've had men say to me, well, what do you mean? You can't get breast cancer, you're a man. And so there's so much misinformation. So addressing that, continually putting out information is so important. Yeah, and about my family members, clearly both daughters were quite upset hearing about the possibility. And of course began reading a little bit. And I think one tends to go to the most extreme kinds of things of, well, what am I going to do about this? And feel like, oh my God, my life is over almost. And then you kind of work back from that point. And so as a parent or a family member, I think listening very deeply and sensitively and compassionately and reflecting is so important, and continually giving clear messages. And those messages don't and can't sink in all at once, because there is so much fear. So I can say something and think I've communicated it clearly, and yet the person who's listening just may not get it. It reminds me of when I was first diagnosed with prostate cancer, and when I was told that, I don't even remember what else the doctor said, right? Because my wife and I were both kind of gone, like, oh my God. So we really have to take the whole person into account and recognize it's a process. And I think that's what genetic counselors, Katie, that you and others are so excellent at doing.
If I may, let me ask a question of our two patients, because you've really been active advocates as I was after my surgery. And that's not a simple decision, and people don't always react the same way. I wonder sort of what kinds of positive and negative reactions have you gotten? And can you say something to encourage others who are dealing with cancer to be more public? What would help them do that?
So I'll start, James. So I would just say that when I started this, I really felt compelled that I have a communications background, and so it's natural for me to want to share my story. I'm a very open person, and it was information, and I felt like I was pretty well read. That, you know, when I learned some of this, I thought others don't know this, and it's important that they know, because it's just really valuable information. And so, you know, sharing my story openly, finding out others that had put off maybe their mammograms or other screenings, then went in to be checked, and sharing with me what they've discovered and thanking me. So I hear regularly from people that you're saving lives by sharing your story. So that makes me want to continue to share my story. And, you know, the light bulb coming on with different people, just like today with, you know, her, you know, sharing that her dad had these 2 cancers, which I know are BRCA2 related cancers. Just because I really think, yeah, I guess I think of the, you know, all of the research that went into discovering this. And we are at a time right now with this knowledge and genetic testing and genetic counseling in medicine. It's just imperative that we use the information that's available to us to change lives. And that's what we're doing.
Yeah. Bo, thank you for the question. And Janet, I completely agree with your last statement. Very, very well said. For me, you know, the dynamic, I think, can be different for men than for women. We men were raised as boys and raised to be strong, silent, and all those characteristics of masculinity, and that some even call toxic masculinity. I know the data, or the health data about men, and men sort of not sharing what's going on with them, not getting health care when they should, dying earlier, not sometimes telling anyone about what they're going through. And I know that that has negative health effects. So because of knowing that, I've worked really since my 20s at connecting with other men and purposefully going against some of those things that we men are taught from an early age, and encouraging other men to do so. So I feel like it's serving multiple purposes. When I share my story, when I am vulnerable with other men, it helps them let down the guard that says, don't be vulnerable, don't share, don't let your weaknesses show. And if I'm willing to do that, I find that people around me are too. I mean, if I don't share that I have prostate cancer, it's very unlikely I'm going to find out that men around me do. And if I do share it, men will come up to me sometimes later and say, hey, me too. And then we've got an hour-long conversation going. It's good for both of us, provide support to me and to them. Yeah, and that's why Us Too is such an incredible organization, and Joel's Cancer ABC, Joel Nowak's support group. We need those. We men need those a lot.
Beautifully said, and I'm proud to say my wife is a social worker too, and I'm not surprised what you bring to the table. Thank you. Heather, Katie, another question you want to bring up?
Let's see.
I've seen a lot of questions, this last one that came in on the Q&A too, about just the difference between genomic and genetic testing. And I think, Dr. Cheng, you reviewed that with your slides, and I think it's, and Janet was asking me to kind of help define this too. And I think the language is really confusing around these different tests. And I think just knowing that there's all types of tests that are intended, that are using genetic information for different reasons, whether it's for prognosis, whether it's for identification of somatic mutations, so mutations that are in the cells of the body or the tumor not inherited, but can help guide treatment, or these inherited mutations. And I guess I would just say the way that we've been talking about genetic testing today is really referring to genetic testing for inherited genetic mutations. And I think that the way we've been referring to genomic testing is really talking about all the other things that fall under that umbrella, right? These biomarker tests, as you pointed out, right? Heather, would you say that's fair?
Yeah, and I think what I would add to that is that the confusion is not just, confusion may reflect changes between different groups also. So the geneticists have certain language that they've been used to using, the urologists do, the medical oncologists do. And that's why, that I showed that second slide about the white paper, about patient groups, advocacy groups, speaking forward, or stepping forward, I should say, and speaking about what's confusing. And part of it reflects a bit of confusion on the level of the medical field, I would say, just to be completely frank. But when it's confusing, ask your doctor and challenge him or her and say, what's the purpose of this? And why are we doing this? And is this for treatment decision making? Like, what information are we going to get out of this test? And how will that be useful? And I think that was something that is going to vary person to person, and we weren't able to get to everyone's questions, but that's something I think the framework is, what are this question? How is it going to be useful? Who is it going to affect? And what's going to be different when we have the result? If you can anticipate that, then it will be much more useful than just saying, because it is changing very rapidly. There's so much more technological advancement and research advancement, all of which is very exciting. And so just trying to ask and have a frank discussion and understand it before you do it will be valuable. And
let me pick up on that before I go to our last question. Dr. Cheng is one of the members of our board of directors, and she's really emphasizing something that all of us at US2 believe, that the patient must be informed so they can make the best decision for themselves, but also for their family and involving their community. So this is really, really critical. It's your body, no one else's. So getting the right information, understanding what's being presented to you is absolutely critical to making informed decisions. So the last question, which did come to us in advance, what is the best timing for intervention? Thus far, I've been advised that it is only useful in extending life a few months near the end of disease progression. I am BRCA2 positive, ADT responsive, currently on an intermittent break from enhanced ADT meds.
yeah, maybe I'll try to answer that question. I think there's two questions, again, going back to what we were just talking about. If the purpose of testing is for understanding risk and implications for family members, then in the pre-Viver setting, there's options for screening. It's a little less clear in some areas. I think there was a question about active surveillance and biochemical recurrence. And so in some cases, it's for the family and kind of thinking about family risk. And on the other setting, and it sounds like the question asker has probably non-metastatic hormone-sensitive prostate cancer. I think it's still useful to know as early as you can know it, because there are clinical trials available. And so even though the standard of care may not include, for example, PARP inhibitors at the hormone-sensitive setting or at the biochemical recurrence setting, I know there are trials in clinicaltrials.gov that are inviting patients who have certain mutations to them in those disease spaces. So if you're thinking about research opportunities, then talking with your doctor about getting some of that information early is going to be helpful. Now, if you're less interested in that, then again, you're not going to use that information to change what you do, then maybe there's not as much of a sense of urgency. So it again is how are you going to use that information for your own care and education to be proactive or not?
Fantastic. Fantastic. I want to thank everyone for the questions that we have had and the answers that you have provided. Please be aware that there will be additional information coming out to you for all of you who have registered and attended. We appreciate your attendance. So there'll be more information coming out to you directly, and there's a great deal of additional information on our website. For example, there is a clinical trials finder on our website as well as at other locations. So we want you to be aware of those. We didn't have a chance earlier to introduce our co-sponsors, ANCAN. I wonder if, Peter, are you available to give a shout out from our co-sponsor point of view at ANCAN? Well, trust me, ANCAN has been an active partner with us in a number of different webinars over time, including this series, and we're very grateful. You might want to go to ancan.org and see what they're doing. They also offer support groups as we do, but they offer a great number of support groups across cancers that might be useful and of interest to you. I also want to thank our sponsors, again, AstraZeneca and Janssen Oncology for their support. They allow us to do the work we do. There's never a charge for the support groups or any other activities that are involved with us too. So we're very grateful to what they allow us to do. Certainly I want to thank our presenters who have been so generous with their time and their expertise as clinicians and as patients. Those are the folks in front of the screen, but there are a lot of folks on, well, not a lot, there are only 5 of us, but all of us on the S2 staff have been involved in preparing this, and we really appreciate all the work going on behind the scenes, both from the S2 staff and our partners with mainstream media as well. We do have webinars coming up in the near future, and here you are. Our next Prostate Cancer Connections webinar will be on imaging. It's coming up on November 19th, and we will be co-sponsoring another program with ANCAN. We're doing a series on active surveillance. The next one is November 30th, focusing on multi-parametric, I think I got that out, MRI for men on active surveillance. If you're not familiar with what active surveillance is, 11 years ago when I got treated, I wasn't aware of it, but now it is what most men with low-risk prostate cancer are using as the first approach. It means that you don't have to have treatment like surgery, radiation, chemotherapy immediately, but you can go years just monitoring the cancer before there may be a need for definitive treatment. So this is a very important topic, and I want to say thank you for ANCAN for joining with us on that series. And let me conclude with one more big thank you for all of our panelists. I think this was really a very powerful session, in part because of the connections between the clinicians and the patients and the audience. And we really appreciate you for all of this and look forward to seeing you again soon. Thank you so much.
And thank you to our participants
Thank you so much.
for your attention. And
Thank
joining.
you all.
Thank you, Bo. Thank you, Janet and James and Katie.
Thank you.
You bet. Thank you all.
Good night.
Good night.
Good night.
Good night.